This next lecture is actually an industry-sponsored CME symposium. It's supported by an educational grant from Astellas Pharma, and it's going to be delivered by Dr. David Wolinsky, who happens to be the past president of the American Society of Nuclear Cardiology and is the section head of nuclear cardiology at the Cleveland Clinic, Florida location, which is in Weston, Florida, and he'll be talking about advances in cardiac imaging technologies, primary care essentials for screening, diagnosis, and CV risk reduction.
Thank you, Dr. Jones, and I appreciate the opportunity to be here. This has been a passion of mine of educating primary care audiences on the value of imaging. These are my disclosures. These are the learning objectives that we're going to go through. Okay. So, just as an introduction of what we've been talking about today, and I've given you a very detailed syllabus. I don't expect you to retain everything that I'm going to go over now, but you'll be able to go back and look at it afterwards. But, coronary artery disease remains the #1 cause of death. Most of cardiovascular disease is #1, coronary disease is half of that. And you can see in the 60s and 70s we reached a peak with the addition of statin therapy, and maybe with the addition of interventional therapy we actually lowered the burden. But over the last few years that risk has remained stable or maybe even increased. We have 1 million or so cardiac events, cardiac MI, cardiac death, first MI, yearly in this country, despite what we've done to reduce cardiovascular risk and primary prevention. Looking a little bit at some subgroups, let's talk a little bit about women. All right? Although the rate of cardiovascular disease is higher in men than women, cardiovascular-related death is highest among women, particularly among black women. Women have atypical symptoms. They're less likely to undergo revascularization, and even when they do undergo appropriate revascularization, their mortality rate is higher. Women with acute coronary symptoms are less likely to have severe epicardial disease, but worse mortality rate than do men. So obviously, find the disease early, treat the disease early, and don't wait till they have an event, and don't wait until they need to go to the cath lab because you may not be able to fix things. Women are more likely to die of MI, stroke, and congestive heart failure, and 2/3 of women who die did not recognize their symptoms. The other thing that you've heard a lot about today is the diabetic population. This comes, by the way, from the American Heart Association, and each year they come out with cardiac facts that are worth looking at. It's a big document. It's about 300 pages every year. But you can just look at it online and get an idea of where we stand from the executive summary. But you can look here on the left, and the slide shows that between 1995 and 2010, we've significantly reduced the rate of acute myocardial infarction and stroke. But when you look at the numbers on the left with diabetic compared to the numbers on the right, which is patients with or without diabetes, you can see that the event rate in the diabetic population is still dramatically higher, almost tenfold compared to the overall population. So we have a long way to go in this diabetic population, and we're going to talk a little bit soon about how do we identify the patient at risk. The other population that we see tremendous increase now in the patient with end-stage renal disease. These patients are no longer dying of stroke, no longer dying of hypertensive heart disease. They will either be on a transplant list, be evaluated for transplant, but half of these people, despite being evaluated for transplant, are going to die of coronary disease, and many die while waiting for their transplant. Transplant helps reduce the cardiovascular risk, but they may still be at high risk, and the assessment of cardiovascular risks in this population remains high. So really, I can sum up everything I'm going to talk about today in this slide. Okay? Why test? We want to prevent sudden death, and we want to prevent a heart attack. And so we did that for a long period of time, and you can see this on this slide as we go from 2000 to 2006, the dramatic increase in cardiac testing that was done. The blue line is myocardial perfusion scanning, the red line is echo, and the bottom two lines are cardiac cath and exercise stress testing. So a dramatic increase in the amount of tests we did with unclear results of effectiveness of risk reduction. And the government noticed this and has made sure that we are all aware of this. So it makes us stop and take a look. What do we really want to get out of a test that we order, regardless of what it is, whether it's cardiology or any other type of test that we do? A normal or near normal test identifies the patients who will not benefit and should not have further expensive treatment. There should be increasing risk associated with increased abnormalities of the scan, with the greatest risk being in a small number of patients. You don't want a test where abnormal is 80% of the population and need another test, but you want the 10% or so who are at the real high risk that you can identify accurately and go on to treat these people more aggressively. We want to increase clinical management. We want to reduce morbidity and mortality. We have to decide value. So, my mantra really is, what is the difference between what we can image and what we should image? Now, what we can image may be what I have the test capability in my office. It may be what the radiology benefit manager allows me to do. But most importantly is, what do I need to do? What does the patient need to know? So why not test? Cost? Significant. Radiation exposure? Small if you're not doing repetitive testing. Lack of incremental utility. If this test just takes me to need to do another test for accuracy, it's not worth doing this test. Do I have treatment that can change the management of a high-risk patient? And that's what value is. And you can go to health policy lectures and you can talk to all the experts in Washington and ask them what value is, and nobody really knows, unfortunately, what it is. So let's talk about risk and value. For those of you who play golf, you'll all know that this is St. Andrews in Scotland, and there's really not much risk associated with me wanting to walk off that or jump off that. I don't need to do any tests. If I want to jump off this bridge, I don't need to do any tests either. I know what's going to happen to me. But here's where risk assessment is important, okay? Is there water in the pool? Can I swim? How deep is the water? Are there alligators in the pool, since I live in Florida? And that's where risk assessment is important. And that's the message that I want to be able to give to you to help you understand for your patients. We start with clinical risk assessment, whether it's Framingham or the Renal score or the global risk assessment, and we can come up with a simple, low, intermediate, high risk assessment of the likelihood of having disease. This is not the risk of an event, but the likelihood of having coronary artery disease. If you're symptomatic, we have gone for many, many years by what's called the Diamond and Forrester criterion, which is three simple facts. What's the age of the patient, what's the gender of the patient, and what's the nature of the symptoms. Exertional chest pain, retrosternal chest pain brought on by exertion or emotional stress relieved by rest or nitroglycerin. That's typical angina. Two of them are atypical angina. And one or less are probably non-anginal symptoms. And you can see here, for instance, in the younger people, in the men to some degree, but in particular to the women, you need to have typical angina before you have a high likelihood of having disease. The younger you are, the more likely you need to have typical symptoms. But we deal with this big intermediate risk populations of patients who have atypical angina that we just don't know. And as a primary care doctor, it's hard for you to do, because where I may have 1,000 patients over a 5-year period, just like this, you may have 10 or 15, and it's really tough to tell. So based on that, we then decided we need to do the next step. And this came from the American College of Cardiology. What is an appropriate test? And I know it's wordy, but I want to read it because you're going to see it in multiple documents that come from your insurers, your payers, and your administrators. An appropriate diagnostic or therapeutic procedure is one in which the expected clinical benefit exceeds the risk of the procedure by a sufficiently wide margin that the procedure is generally considered acceptable or reasonable. For diagnostic imaging, the benefits include incremental information, which when combined with judgment augments care. And these benefits are outweighed by the things that we talked about before. So based on that definition, we came up with what's called the appropriate use criterion. Now, the appropriate use criterion exists for just about anything you want to do in cardiology, but it started with nuclear cardiology and now applies to all cardiac testing. So how many people here are familiar with the appropriate use criterion? Okay. How many people use it on a regular basis? How many people know that they're going to have to start using them soon? So what's unfortunate is I've been giving this set of lectures for about 3 years, and these numbers don't change. The guideline Bible that we use is what's called the 2013 document for the assessment of stable ischemic heart disease and the 2013 multi-modality appropriate use criterion. But this tells us when we should consider doing testing. We have tools that help you to do this, and you can look online. There is the 2013 multimodality appropriate use criterion for the detection and assessment of stable ischemic heart disease. Now, these documents and guidelines and tools have been out for a long time. I remember when I gave my presidential speech at ASIC about 5 years ago, and people said to me, I said, we have to get out of the silos, all right? We may know the documents, but we've been talking to the choir. If we don't get out and educate people, you're not going to be able to understand how to use these documents. And it's not just theoretical, because in 2014, Congress passed the PAMA Act, which was a lead-in to the elimination of the SGR, Sustainable Growth Rate, which you all know that we dealt with from on a yearly basis, November and December, that threatened to cut our reimbursement with Medicare by up to 22%. But it mandated that any physician who orders advanced imaging, CT, PET, MR, SPECT, must use an appropriate use criterion tool that's embedded in a clinical decision support tool. And after 2 years, they were going to look at all the things that you did and tell you that you were a bad person, with nothing in between in terms of quality assessment, updates on how you're doing. And that's caused quite a crisis. Now, we've been able to put this off. It's supposed to go in January 2020. Originally, it was supposed to start in 2016. But we have fought because there are not tools out there to educate the primary care providers. And CMS doesn't even know how to put it into play. So we just wrote a letter to Congress and CMS last week. One letter had 30 societies led by the American College of Cardiology, the other one led by ASA, that's trying to get this delayed. But I wouldn't wait till it finally comes in front of you, because we don't know year to year. The problems are it's not simple. There are multiple appropriate use criteria. Most of us in cardiology, and most of you who refer to cardiologists, are most familiar with the ones that came from the American College of Cardiology and the American Society of Nuclear Cardiology. But ACR, the American College of Radiology, has something called Care Select, which is this large package of AUC for all of imaging. And the question is, what if somebody over there uses one AUC tool and somebody there uses another AUC tool? Who's doing a good job? Who's doing a bad job? And so we looked, and David Winchester, who was here speaking last year, and I published a paper on that, and there was overall poor concordance, that ischemia was rarely seen if you ordered a test inappropriately by the standard criterion, 2.6%. But almost 20% it was seen if you ordered an inappropriate test according to the ACR guidelines. But those guidelines have not been validated. So are they right? Are they wrong? We don't know. And almost 20% of the criterion could not be categorized. So the guidelines that we use, we can't really use them if we're using the ACR guidelines. So it's going to be very, very difficult. All right, so now that I've gone over the politics, let's talk a little bit more about the individual tests and how you use them and some case-based imaging for this. This is the algorithm for stable ischemic heart disease. When it was all published, everybody thought that you guys could all memorize it. It's really impossible to memorize, but we'll focus on some bits and pieces. When you're evaluating a patient with known or suspected ischemic heart disease, and you want to know what test to do, the first thing you need to know is, can he exercise? If he can exercise and his resting EKG is interpretable, he should be referred for a standard exercise test, at least whether he's low or intermediate risk. If his risk gets a little bit higher, you can move over and do an exercise echo or an exercise myocardial perfusion scan. But if he can exercise, you really want to incorporate treadmill exercise into your risk assessment. It's easy to do. It's inexpensive. You can reproduce symptoms. You can assess functional capacity. You can assess our hemodynamic response, heart rate, blood pressure, recovery. Obviously, we can look at their ST segment changes. We can look for arrhythmias. And as I said before, we can combine it with echo or MPI or SPECT. Here's the guidelines from the ACC for people who can exercise. It's a 1A indication. Now, in cardiology, we don't have a lot of 1A indications in our guidelines. So this is about as strong a recommendation as you can get based on the evidence. Exercise stress test with nuclear or with echo is recommended for patients with an intermediate high pretest probability. That's a 1B, and that's still pretty good. So low to intermediate, start with a stress test with treadmill if they can exercise. If they're higher risk, you may want to add imaging to that. There is good value in somebody who can exercise and who can exercise for long periods of time. This is data that came from the University of Virginia, and it's been reproduced several times. But if you look over on the right, those patients who can exercise 10 nets or 3 stages of a Bruce protocol without chest pain or without any EKG changes have a low likelihood of having ischemia, okay? 4.7%, as you can see in the red bar to the right. And a very, very low likelihood of having greater than 10% ischemia. Now, that's important because that's a cutoff, as I'm going to show you, where you need to think about revascularization as a patient management option. If you look over on the table on the right, you can see, again, mortality rates is very, very low in this population. All-cause mortality at 2.4%, with MI less than 1%, cardiovascular deaths less than 1%. And one of the most difficult things that we see is the assessment of women who present with somewhat atypical symptoms. For a long time, the mantra was stress testing is inaccurate in women, that because of digoxin, because of estrogen, it mimics digoxin and can cause a false positive test. And women have poor functional capacity, so there's less of a role less of a likelihood of getting a diagnostic test. But this is the women's study, looking at low to intermediate risk patients who can exercise. And you can see when you compare the gray to the black, stress test versus exercise MPI, there was no difference in the prediction of major adverse cardiac effects. Now, the graph on the right looks like it's different, but the p-value is really insignificant because there were a small number of events in this population. So think treadmill when you can. If it's normal, it's great. You're probably done in most of these people. What about if it's abnormal? Okay, well, take a look at this, and this is a paper that was published about 4 years ago. And if you look in the blue box over on the right, you look at the patients who had positive treadmill testing. Of those patients, only 40% of those people went to have a positive cath or a positive imaging stress test. So the yield on a positive stress test is not as good and is not as helpful as we would like to have. A negative is very, very good. You're probably done with your workup. One that's abnormal will probably, unless it's very, very high risk, needs you to do another test or a referral to cardiology. I think a primary care physician should be comfortable in deciding who just needs a regular stress test and order that before they refer them to cardiology. I think the question, if you're not sure about whether you should do an imaging test with exercise, is worthy of a phone call, not necessarily of a cardiology consult. If you have an intermediate to higher risk patient who's symptomatic, that may be appropriate then to send the patient down to cardiology directly to decide what to do. The Duke Treadmill score has been around for quite a while. And again, it's a simple way to quantify the results of the stress test to predict risk. It's based simply on how far you walk, how much ST segment change you have, and whether or not you have angina that limits your exercise. And you can come up with a score. All right? The low-risk patients do very, very well. The high-risk patients do poorly, but the number of patients who are at risk, who have high-risk scores, is relatively low. But again, a low quantitative Duke Treadmill score is very, very favorable in the patients who don't have symptoms. And it's something that a primary care physician, I think, should be comfortable managing from here on in. So let's talk a little bit more about the disease. I don't know whether you had some of these slides talk about it earlier, but the atherosclerotic process starts with a plaque in the arterial walls, This plaque increases in size based on inflammation by the presence of LDL that becomes oxidized, by macrophages that go in and gobble up the plaque. Then these cells rupture as foam cells that lead to an enlarging plaque. Most of the time this inflammation heals over, forms a little bit of basically a scar within the wall that's calcified. We can measure this calcium to determine whether there's plaque in the arteries, but the correlation between plaque and obstructive disease is something that needs to be answered beyond that. So let's talk about a calcium score. Okay, most of you are familiar with it. If you haven't ordered it, you've certainly had patients who've had chest CTs ordered that describe calcification in the coronary artery. And what this is really stable plaque. It's a marker of disease, but it is not a marker of instability. And it is not necessarily a marker of obstructive disease. The more hamburgers you eat, the more plaque you get, the higher the calcium score you get. But that's a real good division. 0 to 10, 10 to 100, 100 to 400, 400 to 1,000, and greater than 1,000 are really kind of the risk categories that we use when we separate these. And when we look at these quartiles, we can look on here because coronary calcium is a window into ischemia. It doesn't mean you have ischemia. It doesn't mean your patient's going to die of a heart attack, even if he's got a calcium score of 2,000. And I have many patients with calcium scores of 2,000 who have not had a cath, who have lived for 10, 15 years without having a cardiac event. But if you look down on the bottom on the x-axis, you can see the pretest likelihood of disease from Framingham. And then you add the calcium score, less than 10, 10 to 100, 100 to 400, and greater than 400. And on the y-axis, you see the event, the likelihood of having ischemia. Not an event, but a likelihood of having ischemia. And you can see that there's very, very good risk stratification. If you're low pretest likelihood and you don't have coronary calcium, you're unlikely to have ischemia. If you're high pretest likelihood, but you don't have coronary calcium, you're low likelihood to have an event. On the other hand, 58% of people have ischemia. So if you have a patient who has high pretest likelihood, maybe has some symptoms, you might want to think about doing a calcium score and a stress test on them, and we can talk about that later. So just as we can stratify risk with calcium scoring and we can stratify risk with exercise testing, we have even more fine-tuned our ability to stratify when we talk about myocardial perfusion imaging, and that's where the rest of the lecture is going to be. A normal scan is associated with a less than 1% risk after normal stress myocardial perfusion imaging. Now, we have to look at it a little more carefully because if it's a 50-year-old male with no history of coronary disease, and that's young from my perspective now, his risk is very, very low, 1 year or 2 years. On the other hand, look at the 80-year-old male with a history of coronary disease. His stress test gives him a little bit of protection for the first year, but 18 months afterwards, if he comes to see you with chest pain, you're probably going to have to think about studying him again. The other thing is look at the first two sets of slides and look at the patients who can't exercise, the patients who undergo pharmacologic stress. Their risk is 10 times those, even if their scan is normal. If you can't exercise, that's associated with increased cardiovascular risk. Not necessarily coronary risk, but increased cardiovascular and overall risk, and certainly raises your interest in looking for coronary disease. We can quantitate this. There's 17 segments on there, and we can put a number from 0 to 4 in each of the segments. 4 being the worst, and we can come up with a total score maximum of 68. Based on the score that we put in there, we can calculate what's called the total perfusion defect. And we'll talk about that because if you have a score of 10% or more, which would be a 7, that puts you at a little bit higher risk. So this is a study as an imager I quote for a long, long time. This comes from Cedars-Sinai. It's an observational study of over 10,000 patients. And it looks at the severity of ischemia associated with the outcomes with medical and revascularization. And you can see that the lines cross somewhere between 10 and 12%. Those who have more than that ischemia do better with revascularization. Therefore, it would be reasonable to proceed with angiography in these people. Those who have less than 10% do better with optimal medical therapy. Now, it's not a randomized study. we'll need to wait for the results of the ischemia study to look at that. But multiple studies with multiple imaging technologies have shown that you can risk stratify based on the amount of ischemia that you have. Here's a good example of what I call a high positive stress test. Okay. So what you can look here is bright is normal and dark is abnormal, and you can see in the 3 sets of views, when you look on the top set of views between 9 o'clock and 12 o'clock, there's a large area of decreased counts. When you look in the 5th and 6th line, you see a decrease in perfusion of the apex and the infra-apex, and when you look at the bottom 2, you see on the top images a blue area at the tip of the heart. In addition, you can look at the donut hole, look at the top line versus the middle line, and the donut hole is bigger. That's called transient ischemic dilatation. And all this is associated with a large amount of myocardium at risk. So if you see a large total perfusion defect, if you see transient ischemic dilatation, or if you see multiple vascular territories involved, you know you're dealing with a high-risk patient. And in fact, the guidelines for coronary angiography and revascularization took that information and said these are the criterion that we're going to use for risk stratification, deciding whether somebody should be undergo coronary angiography. So severe left ventricular dysfunction, large perfusion abnormalities greater than 10%, significant stress test EKG abnormalities, a fall in ejection fraction, stress-induced dilatation, wall motion abnormalities with dobutamine at a low level. Those are all associated with high-risk score. And just as we have appropriate use criterion for imaging, we have appropriate use criterion for procedures. So you can see here in the red, yellow, and green that the more you have an abnormality, the more likely you are to be a candidate for revascularization in line 2, intermediate or high-risk findings on multiple drugs, appropriate indication for PCI, okay, on no anti-anginal therapy may be appropriate for PCI. If you add the left anterior descending artery involved based on the scan or the angiography, then you've significantly increased the number of patients who are candidates for revascularization. So I've talked about appropriate use criterion, and I've talked about results and testing and high-quality testing. Does it really make a difference how we use these appropriate use criteria? And in this particular paper, it's really very, very clear. If you look at the red arrows, when you have appropriate testing, and you compare the abnormal versus the normal MPI with a very, very high p-value, the incidence of death, cardiac death, death or MI, or cardiac death or all MI, are significantly different between those patients who are abnormal versus those patients who are normal. On the other hand, if you look at patients who are referred for tests for inappropriate reasons, regardless of what the tests are showing, normal or abnormal, there's very, very little risk stratification. And I can also tell you that the cost associated with revascularizing these people to save one life is about 10 times higher than it is if you did it for an appropriate indication. So let's go back now to the graph that I've shown you a few times on stress testing. We have an older population. We have a more debilitated population. We have an obese population. We have a population that doesn't exercise. And some people can't exercise and they can't get on the treadmill. Or they're not able to adequate exercise to at least 2 stages to 85% predicted heart rate. In these cases, we can offer these people what's called pharmacologic stress testing or vasodilator stress testing. We can use dobutamine for echo. We can use vasodilator stress for MPI. And what this tells us is we really can image anybody who comes to our lab just about, whether they can exercise, whether they might be able to exercise, or whether they can't exercise. It has the same predictive accuracy whether you use dipridamole, adenosine, or regadenoson to stratify high and low risk patients. One of the advantages of regadenoson, which is now used in 90% of labs in the country, It offers you the ability to switch on the fly so that you can try exercising patients, get reproduction of their symptoms, see how far they can go, see if they start to wheeze, see if they start to cough, see if their legs start to hurt, and why they can't exercise. And if they don't achieve an adequate workflow, you can switch to vasodilator stress right there. Vasodilator stress has fewer side effects than dobutamine does, which is the common pharm stress agent for echo, and I'll show you some of these things in the next few slides. In our lab, we use approximately 60% vasodilator stress on our patients with MPI, and probably 10 to 15% of patients who undergo echo have vasodilator stress. There's a variety of reasons I said is why people can't walk. And the population is aging, and most of these people cannot exercise well. Here's a comparison of the risk predictors between exercise stress and pharmacologic stress. You see they look identical. And when you look at the safety here, we use primarily regadenoson for MPI. We use dobutamine, which is in the second column, and you can see negligible side effects from pharmacologic stress with regadenoson compared to dobutamine or adenosine or dipyridamole. And it does not have the risk, if those of you who use stress MR, gadolinium-related side effects. The EXERT study was a study that showed that you could convert people on the fly, showed very effectively that it was safe to study these people. And so MPI really is a test that can be used on intermediate risk, on high-risk patients. You can do it with rest or with exercise. Another advantage is if you don't like the picture, you can take a second picture. If the patient's not cooperating, you can get them off the table, say, take a break, lie down in a few minutes, we'll try again. Coronary CTA, which is the angiographic study, the anatomic study, very good for low-risk patients, very, very high predictive value. If you don't see disease, you don't have disease. Best to rule out disease, but it's limited by dialogy. It's limited by irregular and rapid heart rate. You need to be able to take high dose of beta blocker to get your heart rate down. And it's limited if you have high calcium burden, because that calcium can cause bluing artifact, and you can't really see what's there. And you can't really do it over again if you don't get a good results. Here is the multimodality AUC presented in a different form, but you can see here in the second column, stress RNI is appropriate for all of those people, whereas in CTA, most of the time it gets a yellow rating. I suspect that will be changing, though, over time. So the biggest study that's come out, although I did this slide prep before the Scott Hart study came out a couple of weeks ago at the European Cardiac Society. But this is a study that compared functional imaging, stress echo, stress test, stress MPI, versus anatomic imaging with CTA, with the hypothesis that anatomic imaging would be better predicting events. And what you can see here at 42 months, there was no difference between functional testing and anatomic imaging. But if you want to break down the data a little bit more, you can see here that CTA was associated with 50% more invasive cath, double the increase in revascularization, and double the increase of coronary bypass. So we're doing a lot more things to people without getting any better results. And this is the cost analysis that was presented at the ACC. Was not published because I guess the authors did not like the results of it, but you can see here that there was a difference in cost. And anatomic testing is higher at 36 months by $700 than functional testing. So we're spending more money, we're doing more procedures, but we're getting the same outcomes. And I think what that doesn't necessarily negate the role of CTA, but it validates the role of myocardial perfusion imaging. So let's look at a couple of cases here. A 57-year-old woman presents to her oncologist for evaluation of breast cancer and contemplation of surgery. Her ejection fraction is 42% with wall motion abnormalities that suggest both the LAD and maybe the right coronary artery, and she's referred for evaluation. Long-standing history of insulin-dependent diabetes. Makes you worry again. Okay? LDL we don't have available. The EKG is within normal limits. She gets chest pain after walking a quarter of a mile. Now, if she were 80, you wouldn't be worried about that. But at her age, that may be abnormal in somebody who's a diabetic. So if you look at the appropriate use criterion, she's intermediate pretest probability of coronary disease. She's able to exercise. Everything that has an A next to it is appropriate to do. Stress RNI, stress echo. Coronary angiography is not. She underwent stress myocardial perfusion imaging, and what you can see here, again on the top lines from 9 o'clock to 12 o'clock, there's a large perfusion defect. If you look in the mid-left, you can see the entire septum on the left has no counts. And you look in the mid-right, you can see the anterior wall and the apex have no counts. She has a sum stress score of 23%. 23% over 68 is somewhere around 30 to 40% of her myocardium. She underwent coronary angiography. She had a severe stenosis of the right coronary artery that you could see down at the bottom at 6 o'clock. She had severe stenosis of the circumflex, again, that you could see down at 6 o'clock, and total occlusion of her left anterior descending artery that you could see at about 2 o'clock. So she was referred for CABG. And just as we have guidelines again for CAC, we have guidelines for revascularization, and in this setting that it is reasonable to choose CABG over PCI for complex triple vessel disease. And I don't have time to go into it, but studies such as Freedom and Berry 2 also suggest surgery as a better option. So let's talk a few more minutes now about diabetes. We all know that 20 years ago, Steve Hafner published this paper that defined the atherosclerotic equivalent, that a diabetic who had not had an MI had the same likelihood of having an event as a non-diabetic who did have an MI. And so the question became, if all these diabetics are at risk, should we really be testing them? Well, as we go from 2004 to 2014, you can look at the dramatic increase in diabetics. We can't certainly test everybody, okay? Now, the other thing is, are they at risk? Do we want to test them all the time? And here you can look at symptographic progression. This is a study that came from Mike Zellweger. 78% of diabetics who were stressed had a normal initial scans. And the likelihood of them progressing if they're normal was less than 5%. So not everybody is a walking time bomb with diabetes. But if you have disease, you are at significantly increased risk. And this comes from the risk registry. And if you look at the blue line on top, you can see that your risk over 4 years is 16.4% if you have diabetes and you had known atherosclerotic disease. This is Choosing Wisely that you're probably familiar with. I'm not going to go over this, but it's recommendations, in this case by the American Society of Cardiology, of things that you should not do. You should not be testing low-risk patients. You should not be testing people who are asymptomatic, and you should not be doing yearly tests on people. What about this one? This one's a little more difficult. 64-year-old asymptomatic female. Diabetes, hypertension, hyperlipidemia, former smoker, obese. Mild dyspnea on effort. Should she have a stress test? Does she have symptoms of coronary disease, or does she just have symptoms of deconditioning? It makes a difference. You need to take a history. That's one of the problems when these people show up in the emergency room, where they get evaluated for about 12 seconds by somebody before somebody looks at an algorithm and decides to do something. But if they're symptomatic, stress imaging is very appropriate. If they're not symptomatic, in number 9, then stress imaging may be appropriate or may not be appropriate. So it really starts with the history, not the appropriate use criterion, and that's the argument I'm going to make for you. Think about what the patient first, look at these algorithms second. So many, but not all patients are diabetics are the atherosclerotic equivalents. Those who do have disease have worse outcomes. Those who develop CAD need to be watched very closely. Testing may be necessary to decide which pathway patients end up in, but low-risk patients are not ticking time bombs. Here's another case, an elderly male with chronic coronary disease, age 65, routine stress test. This led to CAT and PCI. He wasn't elderly at that point in time, I might add. A year later, despite being asymptomatic, a repeat coronary angiogram, no stenosis. A year later, SPECT anterior wall MI showed anterior wall ischemia. Therefore, he had a CAT that showed it included a diagonal branch, medical therapy. 2 years later, another MPI. He was told to consider coronary bypass because stents were not possible for him. He sought a second opinion and said, do I need another stress test? Do I need a different test? Do I need a bypass? He's been asymptomatic throughout. So these are the guidelines that are really tough to look at, because this says after 2 years after a PCI, even if you're asymptomatic, it would be maybe appropriate to do a stress radionuclide test on somebody, or a stress echo, or a stress CMR, or even a stress EKG. But we don't know whether that means 2 years, 3 years, 4 years, 5 years, 6 years. We can't continue to do it every 2 years on everybody who's had a coronary intervention, particularly if they're asymptomatic. And SCAI, Society of Cardiac Angiographers, says avoid performing routine stress testing after PCI without a specific clinical indication. Now, MPI works in the elderly people, all right? It is a good test to do if it's done appropriately and for the right indication. You can see here that a high stress score is associated with a very, very high risk. And if they cannot exercise, and therefore refer to pharmacologic stress, whether they're under 55, and particularly if they're older, the risk is much, much higher if they cannot exercise. So we didn't do anything to the patient, but he came back 3 years later. Then he had decrease in exercise capacity, but he also developed peripheral vascular disease, and they needed an aortofem bypass. He stopped walking. He was short of breath after walking 5 minutes. No angina. Is testing appropriate here? Now we have vascular surgery with one clinical risk factor. We have new symptoms that he didn't have before. Then a test would be appropriate. He had a myocardial perfusion scan that showed mild anteroapical reversible defect. This was a low-risk scan, and he went on to surgery and did well without any problems. 50-year-old female presents with 5 episodes of retrosternal chest pain, prior calcium score 48, LDL 117. You wouldn't think that she would be high risk. You wouldn't think that she had coronary disease. We referred for a treadmill test. She had typical chest pain at 5 minutes with 2 millimeters of SC segment depression. Her angiography showed 95% lesion in the LAD. She had PCI. She did well for 2 years, then came back with 3 episodes of chest discomfort while walking, but she had a respiratory tract infection, and she really didn't know what that was. This time she's symptomatic. She has an ischemic equivalent. She's post-revascularization. Now it's reasonable to do an MPI in this person. She had a stress test done. It was absolutely normal, and she's done well since. So, and I'm going to skip this case for time, just to move on. I want to talk a little bit about Refer Wisely. Okay, this is, if you want to know more information, this can be obtained at asnic.com, Refer Wisely. This is a program that I've developed with the American College of Physicians to educate referring providers on the value of testing in the management of patients with suspected coronary disease. It is not a guideline on how to use the appropriate use criterion. You need to learn better. We have tables in there that you could look and you could download and print out and put in your office. We have videos. But we really want to focus on what are the questions you need to answer, what test will provide those answers, and are you using the results of the test properly? Because if you send somebody to an interventional cardiologist with a mildly abnormal stress test, both the patient and the interventionalist are probably going to expect a coronary angiography, and it may not be indicated. We have this also online, and you can look at it at the website. We have social media, which this lecture actually eventually will probably and hopefully be put on, and that references in the lecture. So what's the take-home? The role of non-invasive testing has evolved over time. The goal of testing is not just to confirm the diagnosis, but to risk stratify. Risk stratification is effective only if appropriate therapies are applied based on test results. AUC exists to confirm decisions and not the need to test. SPECT MPI is a highly effective tool to manage intermediate to high-risk patients with known or suspected coronary disease. And patients with a normal SPECT MPI have low to 1 to 2 year cardiac event rates, whereas patients with greater than 10% burden have indications to proceed with revascularization. I want to thank you for your time. We'll take some questions later. I'm sorry I went a few minutes over. Thank you.